هذه الجلسة معالي نائب وزير التعليم العالي الدكتور المهندس المعماري أحمد السيف. سوف تكون الجلسة الأولى وسوف يترأس هذه الجلسة الدكتور عبد الرحمن الطاسان مدير عام مشاريع وزارة التعليم العالي. سوف تكون عن الاتجاهات الحالية في تصميم المباني الصحية وفصل خطوط الحركة الخارجية والداخلية في المستشفيات، وأيضا الدليل الطبي على أن عناصر البيئة المحيطة تؤثر في معدل نمو الأطفال المولودين قبل موعدهم الطبيعي. أما الجلسة الثانية والتي سوف تبدأ الساعة 12:45 وسوف يترأس هذه الجلسة الدكتور غازي العباسي الأمين العام للهيئة السعودية للمهندسين. سوف تكون معايير تخطيط وتصميم المستشفيات، ما هي الاختلافات بين المعايير والاتجاهات المستقبلية بغرض التوافق وتقليص الاختلافات بين الأكواد والقوانين، تصميم المباني الصحية والتي توفر الحلول الإبداعية والملائمة للعادات والتقاليد المحلية والتي تساعد على توفير البيئة المناسبة للمرضى وكذلك طاقم العمل، تطوير عملية التشغيل في تصميم المباني الصحية هي طبعا الجلسات لهذا اليوم. الآن نرحب أجمل ترحيب بمعالي نائب وزير التعليم العالي المتحدث الرئيس في هذا الملتقى الدكتور المهندس المعماري أحمد السيف، والذي سيتفضل بإلقاء هذه الكلمة.
بسم الله، الحمد لله والصلاة والسلام على أشرف الأنبياء والمرسلين. أولا أشكر وأتقدم بالشكر للأخوة الزملاء في الجمعية السعودية للعلوم والعمران على دعوتي أولا وعلى اختيار هذا الموضوع الهام الذي يعتبر في حقبة زمنية هامة، حيث تحظى المستشفيات سواء في وزارة الصحة أو المستشفيات الجامعية في المدن الجامعية بدعم كبير من حكومة خادم الحرمين الشريفين الملك عبد الله بن عبد العزيز وسمو ولي عهده الأمين وسمو النائب الثاني، وهناك دعم لا محدود ورغبة في تطوير ونمو هذه القطاعات بشكل كبير. النقطة الأخرى ما سوف أقوم بعرضه هو جهد لزملاء يتقدمهم أخي وزميلي المهندس دكتور عبد الرحمن الطاسان مدير عام إدارة المشاريع وزملائه في الإدارة، وأنا ما أنا إلا بوليسي ميكر. جميع ما ترون وجميع يعني ما تشاهدون هو جزء كبير مما يقوم به المستشارين في الإدارة العامة للمشاريع، وهم من أنجزوا المدن الجامعية. سوف ألقي الضوء على أولاً على المدن الجامعية. احنا لدينا الآن 24 جامعة حكومية بمدن جامعية. معدل مساحة هذه المدن الجامعية تتراوح ما بين 8 إلى 10 كيلومترات مربعة لكل جامعة. البروجرس في هذه المدن الجامعية غالباً أنشئت البنى التحتية وما يتجاوز 30% من الكليات. في كل مدينة جامعية يوجد كلية طب، فإحنا نفترض أنه هناك 25 كلية طب، ويتبعها أيضاً الكليات المشابهة، كلية العلوم الطبية، كلية الصحة والتمريض، الكليات المتشابهة. ولذلك لجأت بعض المدن الجامعية إلى تسمية المدن الطبية، والمدن الطبية هي منظومة عناصر من المستشفى الجامعي وكلية الطب والكليات المساندة اللي هي كلية الصيدلة وكلية العلوم الطبية وكلية الصحة وكلية التمريض. فألقوا عبارة المدن الصحية أو لهذه المنظومة من الكليات. المستشفيات الجامعية وجدت كضرورة في المدن الجامعية لأنها جزء لا يتجزأ من كليات الطب، وأصبح بالنسبة لنا في وزارة التعليم العالي حينما توجد كلية طب يجب أن يتبعها مستشفى جامعي. وتحددت ماهية أو وظيفة المستشفى الجامعي بثلاث وظائف رئيسية: الوظيفة التعليمية الصحية، وظيفة التثقيف الصحي في المناطق، ووظيفة العلاج الوقائي أو العلاج المباشر. ونفترض أن هذه الجامعات الناشئة التي في المناطق النائية بوجود كليات الطب وبوجود المستشفيات الصحية، فإنه الثلاث أبعاد الرئيسية من التعليم الجامعي الصحي وأيضا الدور الثقافي الصحي لهذه المجتمعات والدور العلاجي أنه يرتقي ويتكامل مع ما تقوم به وزارة الصحة من خدمات مباشرة، حيث أنها المناط بها الخدمات الصحية مباشرة. ولذلك يفترض أن جميع الخبراء الذين يأتون لكلية الطب في هذه الجامعات سوف يكون أيضا دورهم خدمة المجتمع المحلي في المناطق، والقيام بدراسة وأبحاث للأمراض المستوطنة. احنا نفترض أنه هناك أمراض تختلف من منطقة أو أخرى. أيضا الثقافة الصحية سواء من الدايت، من التعامل، من الهواء، من الأرض، أن هذه كلها تكون يعني عوامل لإيجاد بيئة من الأمراض أو إيجاد أيضا بيئة صحية. ولذلك يعني تكون فرصة لأعضاء هيئة التدريس وأيضا للخبراء الأجانب من يقوم بالتدريس في كليات الطب أن تكون المجال البحثي الطبي مهيأ لطلاب وأعضاء هيئة التدريس. أنا سوف أتحدث وسوف أدع سلايد يعني تشاهدونه. فالبحوث اللي تقوم بها المستشفيات وكليات الطب هي مهمة. وأنا شاهدت حينما كنت مديراً لجامعة حائل دور كلية الطب في النهوض بالمجتمع المحلي، وكان هناك يمكن قافلة طبية تذهب إلى المناطق النائية والبعيدة في القرى والهجر وأبناء البادية، وتقوم بدور كبير جدا في حماية الوقائية الصحية. على سبيل المثال يعني ما يتعرض له الإنسان أحيانا من أمراض ما يكتشفها، ويقوم الفريق الطبي، أيضا الفريق الطبي يقوم بتجميع معلومات، أحيانا يكون للرحلة هدف. وقامت أيضا كلية الطب بمساعدة مستشفى الملك خالد في حائل أحيانا في خبرات باتفاقيتها مع جامعة روان الفرنسية، خبرات قصيرة يأتون أسبوع أو أسبوعين أو ثلاثة، فيكون أيضا هم مهيئين للمستشفى أنهم يقومون بخدمات. وأتذكر أنه في حالات إسعافية خطيرة توصيل أوردة من حوادث كان لوجود بفضل الله سبحانه وتعالى بوجود هذا الشخص أنقذ يعني حياة. وهذا اللي نتوقعه من وجود المستشفيات الجامعية وكليات الطب. المستشفى الجامعي لديه أنشطة أكاديمية ولديه أيضا أقسام، ولديه خدمات خاصة، خدمات مساندة وخدمات مساعدة. قمنا في الوزارة بتصميم مستشفيات، وكان لسرعة العمل اتخذنا نموذج واحد عمم على المدن الجامعية. سوف أناقش هذا الموضوع في نهاية حديثي بالعوائق وبعض الصعوبات اللي ممكن يعني تلافيها والاستفادة منها في هذا الملتقى. حينما قمنا بتصميم المستشفيات الجامعية صممت على مساحات كبيرة جدا، وأعتقد أنه ممكن مساحة المستشفى الجامعي تتجاوز 100,000 متر مربع البلت اريا، وهذا يعطيك حجم المساحة الكبيرة، سواء مساحة أفقية أو مساحة رأسية. يعطيك أيضا الأبعاد الصيانة لها وأبعاد حركة المرضى واتصالهم بغرف الخدمية، سواء غرف الأشعة أو مختبرات، أو أيضا وصولهم للعمليات الجراحية. فأقدر أقول أنها كانت مستشفيات جاينت من حيث الأوبريشن، من حيث إدارتها. يأتي بعد ذلك المشكلة اللي واجهناها وهي التكلفة. فكانت التكلفة لسعر المتر، التكلفة الإجمالية تتجاوز 1,200 مليون لكل مستشفى، وهذا يعني سبب معوقة في تنفيذها واعتماد المبالغ. ولذلك لجأنا إلى قطع جزء من مكونات هذه المستشفيات وتقليل المساحة المبنية، ووصلنا باتفاق مع وزارة المالية إلى مبلغ لا يتجاوز 400 مليون، ونفذ عدد الآن من المستشفيات الجامعية. هذه السلايد اللي ودي أقف عندها الآن. دعوني أرجع إلى الخلف. يمكن معلومة نسيت أقولها، إنه عدد المستشفيات الجامعية اللي نشأت عليها المرحلة الأولى في خريجي كلية الطب كانت 4 مستشفيات. مستشفيين في جامعة الملك سعود، مستشفى الملك خالد والملك عبد العزيز، ومستشفى في جامعة الملك عبد العزيز، ومستشفى في جامعة الدمام. هذه هي المستشفيات الرئيسية التي خرجت الجيل الأول، والذين يعني قاموا بنهضة صحية، وخرج منهم بايونيرز، منهم معالي وزير الصحة، منهم جراحين في القلب، منهم في الأوعية، منهم في الغدد. هذا هم الرعيل الأول اللي كونتهم كليات الطب والمستشفيات الجامعية. طبعا كليات الطب كانت محدودة، 4 كليات، وكانت تقبل 50 طالب، ومن هنا كانت العدد محدود والجودة عالية. ولذلك يصبح التشالنج قوي جدا في المرحلة القادمة، أن كيف نحقق لهذا البلد جيل جديد من الأطباء والممرضين والصحيين الذين يستطيعون متابعة أو الإنجازات القديمة ومواصلتها بجيل جديد يستطيع أن يرتقي بالخدمات الصحية. القفزة الكبيرة ما بين، إذا تشوفون في السلايد، القفزة الكبيرة ما بين المستشفيات القديمة والجديدة، وصلنا إلى 17 مستشفى الآن تنفذ بقيمة إجمالية يمكن أكثر من 8 مليار. ولدينا أيضا حدود 7 مستشفيات في الطريق. ولكم أن تفترضوا كل كلية طب لها مستشفى، وكل جامعة حكومية الآن فيها كلية طب ومستشفى. هنا يبقى سؤال عن الجودة فيما بعد، وهو تشالنج أمام الوزارة، وزارة التعليم العالي، وتشالنج أمام مدراء الجامعات وعمداء كلية الطب، إنه الجودة لما تم في الجيل الأول يتبعها في الجيل القادم. أعود إلى التصاميم. التصاميم كما ذكرت كانت يعني كبيرة جدا، تتجاوز 100,000 متر مربع للمستشفى الواحد، وكانت تأخذ البعد الأفقي والبعد الرأسي، ومن هنا يجب أنك توازن ما بين آلية العمل. يذكرني أحد المستشفيات، مستشفى الحرس الوطني، أول ما بدأ كان العامل فيه عامل أفقي، وكانت المسافات متباعدة جدا، ولك أن تتخيل مريض يخرج من غرفة العمليات ويصير له نص كيلو أو كيلو على بال ما يصل إلى غرفة الخاصة فيه. لكن بعد الكثافة في الاستخدام أصبحت هذه المسافات متقاربة الآن لمن يزور، لكن من زار المستشفى قبل 20 سنة يشاهد الموضوع. لدينا الآن كما ذكرت حوالي 17 مستشفى تحت التنفيذ بسعة 300 سرير خفضت كما ذكرت، ولدينا 17 يمكن أو حوالي أيضا هذا العدد مستشفيات قريبة للطرح وقريبة للاعتماد. يبقى كيف نديرها في المستقبل. ونحن الآن في مشروع طبي تقوده الوزارة لإدارة هذه المستشفيات بحيث أن الملف الصحي لا يتكرر، فيكون ملف واحد في كل المستشفيات الجامعية. أيضا الجهاز المعقد يكون في مستشفى ويستخدم من جميع المستشفيات، الذي يمكن يحتاجه مريض في 1000 مريض أو في 2000 مريض، فممكن أن يأتي من الجوف إلى حائل أو إلى الجنوب إلى عسير، ويأخذ الفحص على هذا الجهاز، ولا تحتاج أن تكرير هذا الجهاز في كل مستشفى. أيضا العناصر البشرية المتميزة أو النادرة، سواء من الأساتذة، ممكن أنهم ينتقلوا في أداء المحاضرات ما بين المستشفيات وما بين كليات الطب. نحن في تباحث في هذا الموضوع، وزميلي الدكتور عبيد العبدلي موجود يرأس مع فريق من جون هوبكنز موضوع الدراسات الأولية. نقاط شبه يعني الأساسية وضعناها، ولكن هناك مباحثات كثيرة جدا في كيف، هذا طبعا سوف يعالج الإدارة الطبية. تبقى الإدارة الهندسية من قبلنا موضوع الصيانة والتشغيل موضوع يعني أساسي ومهم، وتبقى أيضا الإدارة الأكاديمية مهمة جدا في كيفية الحفاظ على الجودة في المراحل الأولى التي تخرج فيها الناس البايونيرز في الطب من السعوديين، كيف أن هذه الجودة تستمر. ولكن الأمل بالله سبحانه وتعالى وجهود الأخوة الزملاء في الجامعات وفي أيضا الوزارة في التغلب على هذه الصعوبات واستمرارها. الإخوان في إدارة المشاريع الزملاء يقومون بدور كبير جدا في إنجاز هذه المستشفيات وتوفيرها إلى المجتمعات المحلية في الجامعات في أقرب فرصة. والإخوان أيضا في كليات الطب هناك طلاب يدرسون الآن، والبناء المعرفي والبناء أيضا البحثي يتم في هذه الكليات، وسوف تلتقي هذه الخطوط إن شاء الله في خلال ال3 سنوات القادمة و4 سنوات بجاهزية هذه المستشفيات، ونرى إن شاء الله منظومة صحية متكاملة تخدم إن شاء الله الجامعات وتخدم أبنائنا وبناتنا الطلاب وتخدم أيضا المواطنين في الثقافة الصحية والعلاجية. نقطة حبيت يعني أؤكد عليها في هذا المجتمع الذي أنا أنتمي إليه، المجتمع الهندسي وبالذات المعماري، وهو يجب أن نفكر حينما نصمم. يجب أن تحكمنا التشغيل، ويجب أن تحكمنا التكاليف قبل أن نبالغ في التصاميم. ويجب أن تكون المستشفيات flexible في التنفيذ، بمعنى أن تكون سيلز. لدي الآن 100 مليون أو 200 مليون، أنا أستطيع أن أنفذ 3 سيلز 2 سيلز، ولكن عبر الزمن ممكن أنه تتوفر مبالغ وتنفذ أيضا بعض سواء ما يطلق عليه الأطباء العنابر الطبية أو الأجنحة أو سمها ما شئت، لكن يكون التصميم فليكسبل ومرن، أنه يستوعب النمو ويستوعب معطيات الحاضر الوضع الراهن من الليميتيشن المالية والليميتيشن التشغيلية. أنا طولت عليكم وأخذت وقت أكثر من حدي، ولكن أشكر لكم حسن الاستماع. شكرا لكم.
شكرا معالي الدكتور أحمد السيف نائب وزير التعليم العالي. الآن يتفضل رئيس مجلس إدارة الجمعية السعودية لعلوم العمران بتقديم هذا الدرع التذكاري، وأيضا رئيس شعبة معماري المباني الصحية. نرحب أيضا برئيس الجلسة الأولى الدكتور عبد الرحمن الطاسان مدير عام مشاريع وزارة التعليم العالي، وأيضا بالأخوة المتحدثين، ونبدأ على بركة الله.
المباني الصحية، وسيلقيها مستر ستيف جو بالاشتراك مع أحمد سويد. وفي المحاضرة الثانية سنتكلم عن فصل خطوط الحركة الخارجية والداخلية في المستشفيات، وسيتكلم عنها مستر كولين كاري. وأما في الجلسة الثالثة سيكون التخطيط المستهدف والأفضل لمواقع المستشفيات، وسيتحدث عنها مستر فيليب هنسن. المحاضرة الأخيرة ستكون الدليل الطبي على أن عناصر البيئة المحيطة تؤثر في معدل نمو الأطفال المولودين قبل موعدهم الطبيعي، وسيتحدث عنها مستر روبرت دينيس وايت، وهو من يشرفني الآن أن أقدم المحاضرة الأولى التي سيلقيها بالمشاركة مستر ستيف جو مع الأستاذ أحمد سويد. الأستاذ أحمد سويد هو معماري HDR في Global Director of Development Principal for King Faisal Medical City, Prince Mohammed Medical City and King Saud Medical City. Mr. Steve Joe is Global Director of Healthcare Strategy, former Hospital Administrator, Scripps Institute from San Diego. العفو، سيبدأ. طيب. سيكون كل سيشن إن شاء الله في 20 دقيقة. أرجو أستاذ أحمد نتقيد بالوقت، يعني سأحاول قدر الإمكان ضبط الوقت.
بسم الله الرحمن الرحيم. شكرا دكتور عبد الرحمن الطاسان. فرصة كثير كبيرة لنا نحن من شركة الHDR إنه نساعد بالملتقى هذا. شكرا كثير للدكتور عبد العزيز الدوسري، دكتور أحمد السيف، ودكتور زياد السويدان على الانترودكشن الصباح. I'll switch to English. HDR has been involved with the Ministry of Health on very prestigious projects. We've had the privilege of working on the most recent three major medical cities, King Faisal Medical City in Abha with Dr. Ahmed Al-Nami, and with Prince Mohammed Medical City in Al Jouf with Dr. Nahar Al-Azmi, and we're currently also working with King Saud Medical City here in Riyadh. So this presentation is not specific about those. It's about current trends in healthcare, and at a high level, this is a highly condensed presentation to keep it within the time limits that we have. And join me is Steve Go, as one of our strategists in healthcare. And we have more details about the projects here in Saudi Arabia down in our booth. We welcome detailed discussions after that. If you're interested, we can share with you a lot more details on the work that we're doing here.
Okay.
So, Steve.
Okay, thank you. Good morning. First of all, please accept my apologies for not being able to speak your beautiful language. This morning, what we want to talk about is the 10 most important trends that we see in planning for the hospital for the future. We want to talk, as was talked about earlier by our previous speaker, is the importance of adaptability and flexibility for the hospital for the future. So having the infrastructure in the hospital so that it is future-proofed, so that in the future you do not need to have major reconstruction as you adopt new technology or new methods of practicing healthcare. Those can be minor modifications to the facility instead of having to build new facilities or doing major reconstruction. Also, it's important to build in new ways of improving healthcare processes, greater efficiency, and using lean methodology. And based on evidence-based design, those design features that actually have been proven to reduce operational costs and improve patient outcomes, as well as designs that help the patient and family experience and give opportunities for the family to participate in patient care, and then the healing environment, integrating early on information and medical technology in the planning and the infrastructure. Also a facility that can help you to attract new staff and retain staff, physicians and nursing staff, and also prepare the hospital to move into the future of ambulatory care, prepare it for the shift of greater amounts of procedures that will be done on an outpatient basis as new technologies and new methodologies in the future.
I would add that when we started the work on our projects here, we had intensive workshops with the Ministry of Health. And essentially these ideas for planning for the future had been adopted by Dr. Al-Rabi'a and Dr. Hushaim and Dr. Mansour Sawahi as our directives for the projects. And all these ideas have been embedded in the designs of the medical cities that are ongoing.
So the message is that it's important that you have not a return on design, like you would have a return on your investment. Your design must meet a return. How will it improve your patient outcomes? How will your design of your facility improve patient satisfaction and reduce your operational costs and improve your staff satisfaction? Here are 12 examples of evidence-based design criteria and the resulting outcomes. So building all patient rooms like you're doing now for your new facilities will reduce infections, will increase privacy, and actually reduce length of stay. It's shown that every time you put an extra patient in a patient room, it increases the chance of a hospital-acquired infection by 10%. So every one of these 12 criteria will have an impact on reducing operational costs and improving patient outcomes. Also, it's important to look at your patient processes and to look at how you are performing every major throughput, every major patient process in the hospital, and rethink that before you begin your hospital design, as well as using simulation tools to actually test the new processes and see how well they work and the impact that it has on the number of rooms and the time it takes to turn around a patient room and to complete a patient process, and using real-time simulation processes. In doing this, we have found in many medical centers that we've been able to reduce hospital-acquired infections with private rooms by 20 to 30%, reduce patient falls by 25 to 40%, reduce length of stay by 1 to 3 days, and have these other types of results just by the type of design within the medical facility.
One of the things we did very early in the design phases of our medical cities is we analyzed several existing designs of hospitals that had been built or working on in the kingdom, and we used a lot of these. Our planners used a lot of these modeling techniques to analyze the distances of travel for patient flows within the hospital, adjacencies of different departments, and came up with metrics that are not only responsive to the evidence-based design ideas that we have learned on an international basis, but also responsive to the cultural requirements here in the kingdom, and focused on what the Ministry of Health needs are. And those detailed statistics basically became our guidelines to build on what we've done before and implement them in the designs of the medical cities.
At a hospital we worked on in Canada, in Toronto, we actually measured the impact of the evidence-based design features on the savings of the hospital. And by implementing private rooms, we knew that we would see a reduction in patient falls, a reduction in hospital-acquired infections, and a reduction in the amount of times that patients have to be transferred between rooms. Every time you transfer a patient, it actually lengthens a patient's stay in the hospital by a half a day. So by going through each of the evidence-based design criteria, we were able to calculate at the end a total potential savings annually to the hospital of over $17 million just by the type of design features. By implementing these savings, it would be an incremental cost of $23 million in construction, but that would pay for itself in less than 16 months because of the annual savings of the evidence-based design. For instance, a typical hospital, a nurse walks in one shift, in one 8-hour shift. She walks between 3 to 7 kilometers per shift, and only spends 19% of her time actually directly with a patient. So out of an 8-hour day, only 19% of that day is actually providing patient care. The rest of the time is looking for supplies, writing in the chart, and other activities that are not directly supporting patient care. So at a hospital in Toronto, Humber River Hospital, we actually looked at the location of support space, the pharmacy, the supplies, of decentralizing that throughout the unit. And in doing that, we were able to show a 17% improvement in the distance that nurses had to walk in surgery, in the emergency department, and 22% improvement in the amount of time nurses had to walk in surgery.
Those same ideas were also from having a central nursing station. Can you back a slide? Central nursing station for the nursing unit, to have touchdown stations for groups of beds, but also having charting stations at each of the rooms. Each of the patient room have individual charting stations to allow for much more closer contact between nurses and the patients, and also allow for decentralization of these services to allow for the better care for the individuals.
Okay. As well as I mentioned that early on in the planning, the consideration of technology needs to be foremost in the planning. And we're seeing within the hospital now a greater use of smartphone technology, personal handheld computers that the nurse and the caregivers carry around with them in the nursing environment, the use of the wireless internet, digital devices, also genetic sequencing, genomic therapy within the hospital, and the use of social networking of patients from their home and physicians' offices. A greater amount of hospitals in the United States are using smartphones, iPhones for, and the applications for disease prevention, being able for physicians to follow their patients using an iPhone and monitoring their cardiac rate, their blood pulse, their blood sugars from their home using smartphone technology, and remote monitoring of the patient in their home and within the hospital. The 6 technologies that we have found that actually improve efficiency and workflow within the patient environment are workflow management systems, real-time location systems like RFID tracking systems, where by using an RFID chip, we can track patients, we can track supplies throughout the hospital, wireless mobile communication, so that a nurse or physician can be located anywhere within the facility, patient monitoring technologies, delivery robots, and interactive patient systems. So robots like this we're using in our new facility in the Beijing Medical Center in Beijing to deliver food, deliver pharmacy, and deliver supplies to the patient units, and has a return on investment between 9 and 12 months with the use of these technologies. On the inpatient trends that we're seeing are the zones that we've talked about, the caregiver zone with the decentralized workstations, and I know that
we did actually quite a bit of discussions about the individual patient room. All the patient rooms are single patient room, as we discussed earlier. But we had a lot of dialogues about inboard toilets, outboard toilets, and from the cultural perspective here, we settled on inboard toilets as opposed to what's shown on the screen here. But also, it's very important to have the family zone in this case, and in addition to having the caregiver zone and the requirements to meet the HGI guidelines, we had quite a bit of work on providing a comfortable family zone in this area to allow for better healing environment and better views for the outside as well. So all these stuff had been very well detailed. Our colleagues this afternoon, Mohammed and Jim, are going to talk a little bit more about those statistics.
Okay. Also, I wanted to point out that in the last 20 and 30 years, the size of the patient room has changed. We're seeing, going in 1980, the use of multi-bed rooms. Today, we see the adoption of mostly single-bedded rooms, and in the future, single rooms with a greater amount of space for the family, and also larger rooms, going from 25 meters in the future to a larger room of 30 plus square meters. Also, a larger number of critical care rooms. In the past, we see maybe only 10% of the beds being critical care. We're seeing now in the future 25 to 30% of the beds, total beds, being critical care, and more space for ambulatory care. 60 or more % of space being dedicated to outpatient care. Also in surgery, we're seeing the merger of operating suites with intervascular suites, interventional rooms, into one procedural platform. And we're also seeing the operating suites becoming larger, becoming greater than 60 square meters, 70 square meters, and for hybrid rooms, over 100 to 120 square meters for hybrid rooms with interactive MRs. The other trend we're seeing is a greater amount of surgical suites, surgical theaters for outpatient. 20, 30 years ago, only 10% of our patients were outpatient. It's forecast that 10, 20 years from now, 75% to 80% of our procedures could be done in outpatient theaters because of the advances in anesthesia and the advances in technology to be able to do more and more cases on an outpatient basis. And
so we have about, I'm not sure how much time we have left. We have about 10 minutes worth of questions.
No, 3 minutes.
2 minutes?
Two minutes.
Oh, 2
Okay.
minutes. And then we sit down. And if you're, we just,
You finished?
yeah.
We'll take this question session afterwards.
We'll take the questions
Yes.
afterwards. Okay.
Okay,
Now we're
thank you.
available this after downstairs also after the session.
Thank you very much. Now, our second speaker is Mr. Colin Carey. He's an architect from Scotland. He has 30 years experience of designing hospitals. Represents Scotland on the International Union for Architects and Public Health Group. He will represent some ideas and talking about the flow in hospitals. Mr. Colin, the floor is yours.
If I can work the technology, I'll be there. I think we're there. Thank you. I'm very pleased to be invited to this conference. Thank you. I'm going to talk about the segregation of flows in hospitals. Strangely, there's quite a bit of overlap from the Minister's introduction about flexibility in hospitals, about travel time. There's overlap with HDR's presentation on evidence-based design. But this is a slightly more practical, maybe, set of slides. First of all, just a few seconds about myself and my company. We've been around for 150 years. We've been designing hospitals for 100 of these years, and 60 years since the inception of the United Kingdom Health Service. So we've been designing hospitals further afield as well. When I first started designing hospitals 30 years ago, I was working extending and altering Florence Nightingale designed wards that were built at the end of the 19th century and the start of the 20th century. And these wards really embody all the things we're trying to avoid with our evidence-based healthcare design. This image on the right-hand side is a current ward. Remarkably, some of these are still in existence, but not for much longer. They do have good daylight, the good natural ventilation, but they have next to no privacy and dignity aspects, and patient care is compromised through this. Segregation of flows are compromised as well. So going on from there, we reach the mid-20th century and latter part of the 20th century. And again, in hospitals across the world, people aren't paying attention to segregation of flows. New, modern, large-scale hospitals are essentially small urban communities, and they act the same way. They're completely open for access. They're busy during the day, somewhat quieter in the evening, but they both have the same requirement to segregate traffic and pedestrian flows. So strangely, hospitals are being designed at the end of the 20th century, and probably still now, where rubbish and electric carts are driven through the public spaces. People haven't thought this through. Again, patients, either in trolleys or in wheelchairs in their dressing gowns, they're feeling very stressed. They're mixing with visitors, mixing with other public, and sharing lifts with visitors. This just isn't good practice. And then there's the wider care teams in hospitals. And this is about training the likes of porters to be more patient-facing, unlike this image in the lower left. In the UK, the Private Finance Initiative and public-private partnering was launched 15 to 18 years ago. And architects were challenged to develop innovative ideas, or at least we thought we were challenged to develop innovative ideas. And through this period, we designed, built, and advised on a large number of hospitals. And after 2 years, the government offered an award at a dinner for the most innovative idea in private finance initiative. So like all the other architects in the country, we dusted down our portfolio, submitted our best hospital schemes, and waited to see if we'd won the award. At a dinner several weeks later, the award went to a firm of accountants for their financial modelling. And it really just goes to show that innovation isn't the same to all people. Undaunted, one of our first large PFI hospitals was the Royal Infirmary of Edinburgh and University of Edinburgh Medical School. And this started to embody segregation of flows at a different level. We had visited Europe and further afield to see what the best healthcare designs were developing. So in this hospital, it's 120,000 square meters, 870 beds, 24 operating theatres. There were several innovations. The first one was to combine medical and surgical aggregations into larger aggregations, such as orthopedics, gastrointestinal, GI liver, and maternity services. And what this meant that with their own operating theatres and ITU, travel distance for the patients were very much shorter than norm in these large hospitals, just as the Minister was touching on earlier. The big innovation here, though, was to provide a basement tunnel system so that electric tugs could serve as dedicated FM lifts with separate bed lifts and separate visitors lifts, and there were separate corridor systems as well. But one of the challenges of hospitals 15 years ago, everyone thought with new technology hospitals would get smaller. And as we were signing the contract for this hospital, they challenged us to say, what do you do with this hospital when you make it smaller? 15 years on, or 10 years since it's opened, we've been extending the hospital ever since it opened, and we're still doing so. The centrepiece of my presentation, though, is about the new Royal Forth Valley Hospital in central Scotland. This opened just over 12 months ago. It's a 100,000 square metre hospital, 700 beds, 16 operating theatres, and is really a very general hospital. It has a hot side with the emergency department, elective patients, and maternity and children's services. So just some quick slides of the public areas. There's the robots appearing again. This is one of the key successes of this hospital, and was the first hospital in the United Kingdom to have robotic handling. Very standard, state-of-the-art modern bedrooms and technical and treatment facilities. More public space views. And again, this hospital was the first in Scotland to have a robotic pharmacy, robotic mail handling systems, and beginning to apply all the technologies that HDR have just reviewed as well. But I talked about hospitals being like small urban communities. One of our initial sketches for this hospital really talked about communities in town terms. We've got squares, we've got districts, we've got entrances, we've got streets. And the very best of these modern hospitals segregates the internal flows so that as far as possible, visitors, patients, and hotel services don't mingle. But this starts at the outside of the hospital. Here we go. And so we're going to start with the main entrance, the wards, just a diagram of the hospital, treatment and diagnostic facilities, women and children, emergency department, mental health. These are linked by V-shape street at all levels, and this is the building blocks coming in. And this hospital sits in a marvelous mature landscape. And again, talking about stress and how people arrive at the hospital, we've segregated the blue light traffic so it feeds directly into the emergency department. Visitor traffic with their own car park and staff car park. Separate bus and taxi arrival, and as soon as possible getting rid of the service traffic to a clean yard and a dirty yard. So this is the premise of all new hospital designs, that you start at the outside segregating flows. Before I come to the inside of the hospital, just to orientate you a bit before these fast diagrams come again, what we're showing here is 2 of the 4 wards on one level. Each ward is 32 beds, 50% are single bedrooms, with 2 of these being isolation rooms, also dealing with bariatric patients. The wards have a very private clinical corridor, this diagonal corridor running down the wards, and this is only accessible for patients. There's no hotel services, there's no visitors. And like all architects, when we design hospitals, wards are about 50%, 60% of the floor area of the hospital. So at Forth Valley, we started with the wards, as we always do. And so the first part of pairing these wards was where the green dot is. I hope you can see that on the screen. We created a hotel services hub, and the robots deliver the cages and the goods up to ward level. They're not seen by patients or humans. There's a clean side for dropping the cages, and then there's a dirty side with a gravity tube system for linen and waste. Then at the other end of the wards, between 2 wards, is the visitors' arrival area. And the visitors come up by lift, and this is like visiting a block of flats. If you get the wrong address, you have to go back down and come up again at the right address. And this accesses the wards at the other end. So on to the internal flows. This is a fairly low-rise hospital, ground floor, 3 floors above, and this basement service tunnel system. Starting with the visitor flows, we have women and children. Women giving birth really aren't ill, they're just giving birth. Children have rights to be segregated from adults. But the main entrance comes through the retail facilities, the atrium, and then links to these vertical visitors' lifts serving between the wards over the 3 stories of wards. We then have our emergency flows. And we have ambulant and ambulance entrances serving the imaging department, and lifts up to the emergency theatres, necessary, critical care and coronary care. The next flow is going to be about the theatre flows, and this is a very different theatre block to the norm. We have 16 theatres surrounding a central reception and recovery space, and the red line for the theatres is at the anaesthetic room door, and this is quite different. And you can see the day surgery, the women's flows, critical care flows into the theatre, and we try to bring them all the different flows in by different means. And this group of 16 theatres are very flexible, so you're able to change from day surgery one day to elective cases another day. But the heart of the hospital success is the segregation of hotel services. We have a clean yard in. We then have 9 lifts that serve all departments out of sight of the public and staff. Rising through the building into each of their FM hubs or hotel services hubs. We then have the gravity chutes for the majority of waste and linen, but clinical waste under UK rules are not allowed to go down these chutes. They get transported overnight before the lifts are cleaned for the day, and then segregation out via dirty yard. And this business of having clean in, dirty out seems a very strong theme for this hospital. So what we arrive at is a basement service area that, other than the pipe services, is the domain of the robots, very few humans. And the upper clinical streets are a very calm, daylit environment with only staff and patients going to treatment and diagnostic facilities. But things move on, and last year I visited Oslo, Akershus Hospital, which isn't one of ours, an award-winning hospital, and they'd taken things a stage further. So what you see on the left-hand side is a conventional section for a hospital anywhere in the world these days. We have wards above the treatment and diagnostic facilities, above the entrance and ambulatory care facilities, and then underneath we have the service, clinical, non-support areas. What Akershus have done is they've provided a service level below this, and in this level they've provided not just the normal tube system, but a pneumatic waste and linen system. And this means that you get this absolute segregation of clean into the hospital and then the dirty out to the service yard. What we've been looking at for the last few minutes is essentially large hospitals, and currently one of the hospitals we're designing is a hospital half the size. This is a 50,000 square metre hospital in the south of Scotland, and the support services don't allow these standard sections to happen. There's a lot held off-site. The client have also determined that they wish a campus-style feel to the hospital. So this has created some challenges in the section. So on the left-hand side, it's a development of the standard section for Forth Valley. But on the right-hand side, what we're really saying is that we just respond to what the client wishes. So we have absolute segregation for the treatment and diagnostic facilities. But when it came to the ward side, there's lots of daylight. We've achieved external views for all the rooms. There's tremendous countryside around this particular site. And the lower ground floor facilities are able to use rehabilitation gardens. One of the innovations of this scheme is that, unlike Forth Valley, where the visitors were held in a windowless lounge, the visitors at this hospital will arrive at a socialisation space between the wards overlooking the wider countryside. And just to end, this is a 1,500-bed hospital for Shenzhen in China, and we developed this last year. It's a much denser hospital, but again a teaching hospital. It's looking out to mountains in the north, overlooks a golf course to one side, really quite rural for China. But it's imposing this same logic of treatment and diagnostic facilities, wards broken into specialties like the Royal Infirmary, and then the education and teaching facilities to one side. And then we've applied the same segregation of flows. But the difference with this hospital, like a lot of hospitals around the world, is the car parking and services yards are underneath the hospital. And although this is difficult in Saudi, it certainly eases the segregation of flows in the hospital. So that's the end of my presentation. Thank you. I don't have quite the same evidence-based statistics as my predecessors, but I hope this has made sense. Thank you.
Thank you very much, Colin, for sticking to the time limit. Our next speaker is Philipp Hinsen from Germany. He's from Maron Rennie Architects from Berlin. He's from Germany. He's graduated from Technical University at Berlin. He has a lot of projects in Germany and Saudi Arabia and UAE. He is talking about master planning for hospital sites. The floor is yours.
Thank you very much for this opportunity to speak here in front of you. Thank you very much for the Umran Society for inviting me. I'd like to speak about master planning for hospital sites. It's tied to this beautiful saying of hospitals having to be future-proof we've heard at the kickoff of this session. And I'll try to give you an insight on our experience in our home country regarding this. So we'll have a quick look at background information concerning the general setup of healthcare system in Germany, then trying to define master planning, have a look at the scope of work, and then go to some planning examples from our office. We basically have three players: medical offices, private practices, health centers, and hospitals in the system. Hospitals are financed one-way operating cost through public and private insurance contributions, and on the other side, investments and building costs are done by a hospital plan, which is generated from general taxes. So hospital plans decides on what amount of money goes to what region and what kind of hospital. So we have a situation where taxpayers are increasingly aware of the money they spend on healthcare, and they want to see it applied in a future-proof way, which on the other side puts pressure on politicians to do so and to demonstrate that they have a master plan for the usage of these taxes. On the other side, we have a tradition of university hospitals. They underwent a century-long development, which means that we have lots of different building typology types on one site. We have individual measures that were constructed during a long period of time, and sometimes this leads to a dead-end situation in terms of improving the healthcare services and facilities. So target and master planning aims at producing a step-by-step development in regard to an overall concept within the foreseeable future. Let's talk about 10 years, 20 years. So it became mandatory for many hospitals in Germany to have this kind of master planning in order to show what their current building measures are, if they are in line with the master plan. So it's a long-term planning strategy, and we focus, of course, on the day-by-day functionality of hospitals, meaning we have a look on the precise implementation of building phases, and we try to illustrate the corresponding planning, equipment, and constructional measures. So the scope of work, so to say, is not a classical architect's scope of work. It's a step that you have to take before actual going into conceptual design. So we start with a survey regarding general situation of the hospital, the real estate, having a look at building technologies, and trying to develop a basis for a schematic approach. Now, the review and audit goes to analyze operating procedures. We have a look at the building construction. What is it made of? Is it flexible for medical use? Should it be used for highly equipped spaces? Can it be used for outpatient department, rehabilitation centers? So those are the questions we are asking here. Based on this, we try to develop a concept. It's based on a room schedule, and this room schedule is like our guideline through the whole project in order to see are we reaching our planning goal, because we always can come back to what the actual situation, the planning situation is, and compare it to our defined goal. We have a look at the plot, of course, defining future land use. You might have to go to local authorities regarding building laws, zoning, and all this, and of course link the future extensions to the traffic you have on site and how patients, visitors, and staff access the facility. We have a look at each building, trying to give it a target planning according to the survey we did, according to the possibility we see for this building. And of course, at conceptual stage, we have the opportunity to analyze quickly alternative solutions without going very much into architectural details. If we know what we want to do, we can go into the stage of describing what the possible construction phases could be, how to implement it without disturbing day-by-day functionality, and of course to relate time and the financial aspects to these phases. Now, target planning, as I said before, is not so much a typical architectural scope of work as we understand it, but nevertheless, the depth of analysis should be looked at very precisely in order to define what are external and internal factors that are relevant here. Now, external determinant factors for the hospital are mostly the marketplace, where what are the competitors in the market, how do I want to place my hospital in this market, and of course we have demographic situations to take care of, and urban planning regulations, political, legal framework coming into play. Now, the internal determinant factors are easier to define. We can have a look at the number of departments. What kind of hospital is it? Is it a general hospital? Is it a specialized one? What kind of medical service do we have? Are we deeply involved in non-medical services? Are there services that are outsourced or not? All this defines the amount of work we have with this master planning. So these factors need to be analyzed in order to have a planning basis, let's say, and to have an idea of a future development within the next 10 to 20 years, taking care of what we were talking about before in the presentations, facilitate orientation, daylight for patients to find their way easy through the different functions of the hospital. I'd like to emphasize one point: if it's possible, if the client accepts this, get MEP people involved from the start. This is really a great additional value if they can, at the conceptual stage, bring in their ideas from the start. I'd like to come to some planning examples. 2 hospitals have master plans that we have been working on, and the other 2 hospitals I'd like to show because they had an architectural, they had their building measures coordinated with a master plan done before. So the University of Hospital of Halle is the first one I'd like to show you. We'll have a look at the historical development, look at how we tackle functional planning and go into the master plan, and then defining construction phases. Now, what we see here is a hospital that's been built in former communist time in East Germany. We started with what you see on the left, 2 high-rises, and in the middle, a low-rise with examination and treatment area. In the next 15 years, ICU units were added, MRI was added, and 2001, a whole new development was added to have a new emergency department, new OR center. Now, the situation is that we have an emergency department and OR center far away from the ICU that's been implemented before. We have beautiful ORs, but we don't have an imaging department that's up to today's healthcare facility planning standards. So this is some of the issues we needed to address with the master plan. You can see the situation in the former communist country, and then the situation around 2001. So this is our start for the master planning. We kickstarted with functional room schedule, listing functional areas, going into the different departments, and looking at every room we might need here. Now, this is transferred very quick into a schematic approach, an isometric stacking model that shows interrelations in between the different departments, vertical and horizontal. We can zoom in, for instance, on this entrance level. We will see that we had these blocks facing the streets and 5 other blocks that will be added in different phases on top of them. Switching from this kind of planning into master plan, we have a look at a brief look, schematic, at how many beds can we accommodate, be it ICU, IMC, or general ward. And then we quickly go into master planning. This is on a scale of 1 to 250, showing every room we had defined in the room schedule. Now you can have a look at the site 2011 and how it will look, hopefully, in 2017. Now that we know what to do, we've defined what the goal is, we have to have a look at how we will achieve this. And we define according to our survey, which are the buildings that are no longer suitable for medical use, that should be demolished in a short or mid-long term, and then the new buildings. Now, how are we going to proceed? We have the opportunity to have a central area without any building. This helps us in integrating the two first blocks. Medical functions within older parts of the hospital site can move in those two blocks. Then we can tear down the second one. And this is the procedure we follow all through the project. You see number 3 and 4 will allocate imaging department, MRI building being teared down, and then at the center of the facility we have block number 5. In 3D sketches, this is the way we are supposed to do it in the years to come. Now work is in progress. It will keep us busy for the next 5 years, I hope so. Now the general clinic of Wetzlar, it's a regional hospital, much smaller, but as I said, mandatory to have a master plan in order to get the sufficient funds and the approval from authority side. Now the approach is quite the same. We look at how did this site develop. We do a survey, what's it like today, and we try to define what's the guideline for future development in the years to come. Future site functions being defined, and at this early stage we can look at alternatives. One would be changing the functions within the building itself. Another alternative would be having a new building added and see how it interacts functionally with what we had. We're doing a relocation planning for this project, which means who has to move where, who is not allowed to have holidays when, what medical stuff has to move where. This is a service to our client we're offering here. From there on, we go to preliminary design, and of course, the financial planning we're doing in parallel with this design. Now, the next two projects are, we didn't do the master plan, but there was a master plan for future extensions being done before, and architectural competitions based on this analysis. As we find here, a big site with a hospital from the 70s. You can recognize a typical layout on the right side. On the left side, we find research buildings, laboratories. And in the middle, the red one was the place for the architectural competition. Now, there should be all the medical functions that are highly equipped spaces. We would have emergency department, OR, central OR, and ICU units. So a complete hot floor to be planned here in order to facilitate the integration of other functions within the building, within the existing buildings. Now you can see that we try to integrate examination and treatment area in the lower levels, so we can have inner courtyards, and on top of that, separated through a passageway, we would have the wards on top. Now the section shows diagnostic and treatment area in the 2 levels below, this passageway in the middle, and then on top, the wards. We go quickly into concept design and then into functional planning. We can see that we have the whole hot floor on one level, OR department being blue, outpatient surgery being done next to it, and on the other side of the passageway we have ICU and IMC units, everything on one level. We go into staff workflow. We have a look at patient access, consumables workflow. We analyze how do sterile goods come into play, and equipment workflows. We can concentrate very quick on defining versions of OR setup in order to be discussed with the leading medical staff. This hospital has been opened end of last year. Last example, implementation of ICU unit in the University Hospital of Freiburg. We have an initial situation that I was talking about at the beginning of my speech. We have a huge site going back hundreds of years. We have old buildings. We have buildings remains from the 60s and 70s. We have added laboratories, research and teaching areas. And now the aim was to have a new ICU unit with helipad linked to this structure we find. We decided to have 3 blocks linked with an internal passageway to the existing buildings and 2 bridges connecting it to the other parts. Now, in these sites, you need to have a quick look, a detailed look at the facade, at proportions, at materials, how they interact with what we find on site. And this is the situation like it is today. So we have 3 blocks with ICU units. You can see the old helipad on the left, the new one at the center of the new development, and the connections that go towards the existing buildings, right, left, and in the back section. Just to some design impressions of the interior. It's always beautiful when there's nobody inside. There you go. Thank you very much. I hope we could find perhaps some aspects in this master planning approach we have that might be of interest when thinking about medical cities in Saudi Arabia. It's more or less the same scale. It's of course a totally different history, but the development shows some aspects that might be of interest. Thank you very much.
Thank you very much, Philip. Okay, the last presentation will be talking about the relationship of design elements, of design environmental elements and the development of preterm infants. Our speaker is Robert White. He's from medical field. He's the chairman of the committee to establish recommended standards for newborn ICU design. Robert, 20 minutes.
Thank you very much for introducing me, for inviting me here. I congratulate you on this effort to bring the very highest standards to the hospitals for the people of your nation. And I want to talk with you about a very special part of the hospital, that is the newborn intensive care unit. This is a special place for many reasons. First, we are taking care of patients who are going through a very crucial stage of brain growth and development, unlike any other part of the hospital. For families, this is often a defining moment. They're usually young families, and they're developing their own relationships with one another, with the healthcare system, and with God. They are searching for answers for why their baby is ill. It's a defining area for staff. We work there, it becomes a part of who we are. And so the design has to meet the needs of each of these constituencies. This is a graphic that helps to demonstrate how important the brain growth is during the time babies are with us. If you look at the furthest to the right in the upper column, that's 28 weeks gestation, and that brain of a baby grows almost 400% in size and complexity in just the 12 weeks when they are with us until they reach term. That is the same proportion of brain growth that occurs in the entire life of a child who is born at full term, and it's occurring in a short 3-month period in a baby who is born that early under our care. And how that brain develops, for better or for worse, is largely dependent on the environment that we create for them. This is another graphic of what's happening. You will see a massive increase in synaptic formation in the brain during the 3rd trimester of pregnancy and then continuing on after birth. And that 3rd trimester of pregnancy is happening under our care in babies who are born prematurely. These next couple of slides detail a number of studies, and I won't go into each of them. I show it only to establish the point that a crucial part of brain growth in these babies has to do with extended intimate contact with the mother and the father. And these studies taken together show that with this extended intimate contact, the babies develop better and do better in all respects after discharge. And this is not unique to humans, of course. This is consistent with a very much larger body of evidence that's been extended to animal studies. So at this point, we know that infants of all mammalian species suffer in the absence of extended intimate contact with their mothers, that skin-to-skin care has been shown to be efficacious in every culture in which it's been studied. But we also know that most current NICUs have been built without taking observation of this finding, and that we as caregivers have done a poor job of recognizing and responding to this science. This is not just about neonatal biology, of course. When we're designing hospitals for people who will be spending extended periods of time there, we need to know about their sociology, about their psychology, even about anthropology and occupational health, if we are really to make these places that are for the healing of the patients, but also for the well-being of the families and the caregivers. So we are working with these premises. First, that babies deserve the best available treatment. Second, that babies and parents should not be separated because of inadequate space or restrictive policies, both of which have been very common in NICUs to this day. And third, that the NICU environment should meet the needs of all those inhabited, not just the babies, as we've tried to pay attention to in the past, but also the families and caregivers. So good NICU design requires space specifically designed not only for the needs of the babies, but also for their families, as well as separate spaces for the needs of caregivers. So this brings us to individualized environments or single-family rooms, which are well accepted in other parts of the hospital, but not so much in newborn intensive care. They probably are a good idea for the NICU, but there may be hazards and pitfalls that we should observe. The rationale for single-family rooms in the newborn intensive care unit is that this is probably the optimal environment for most babies. It allows us to individualize their light and sound control. It reduces infection risk, and it allows more extensive skin-to-skin contact, which, as I've pointed out, has substantive biological impact, and it really approximates the in utero environment that babies would otherwise be receiving if they had not been born prematurely. It's also probably the optimal environment for the family. It gives them privacy for interaction with the baby, privacy for interaction with the medical team when we come to talk with them, and a sense of control and belonging. It's a home away from home for them. Caregivers also benefit from having a space of their own outside of the patient care area, and this single-family room design permits some nursing functions to be separated from the direct patient care areas so that we can provide more appropriate environments for the caregivers. There are many adult and pediatric units that have shown this concept is feasible. There are also now many pioneering NICUs that have demonstrated that it's practical, but they have also taught us that a bad single-family room design can be worse than the current open ward newborn intensive cares. This is just a brief listing of many areas of the world in which this design has started to take hold. In the United States, there are more than 100 units now that are predominantly or completely single-family room design. This is just one quick study that I won't take time to detail the scientific background of, just to demonstrate for you that at Karolinska Institute in Stockholm, that when they switched from an open design to a single-family room design where families could stay with the babies 24 hours a day, they saw a 10-day per patient reduction in the time the baby spent in intensive care. So this is a very cost-effective design process. They also saw a reduction in chronic lung disease, and they are currently doing long-term follow-up to look at the outcomes of the babies at 2 and 3 years of age. This is a newborn intensive care unit in West Virginia in the United States, which saw, after moving to a single family room design, a marked reduction in apneas. These are periods where babies forget to breathe, as well as reduction in the amount of time babies needed to be on intravenous nutrition, an increase in the amount of time they were receiving their mother's breast milk, and a reduction in infection. And of course, a very major reduction in the sound levels in the nursery. Newborn ICUs are notoriously noisy, bright, hectic places to be, and that's not good for the development of our babies. This is a unit in South Dakota in the United States. This is what one of their private rooms looks like. And in their research, they found that families felt that these private rooms were more family friendly. They felt they allowed the staff to work better together. The care given to their baby was improved. The care they received as a family was better. And in a subsequent evaluation that this group has just recently done, they showed that it did not require any change in staffing levels and that there was a 15% reduction in costs. So again, this is very cost effective. It costs more to build, but the return on investment in single family rooms and newborn intensive care units has a rapid payoff. The idea of putting babies in private rooms, though, does have some potential drawbacks. Privacy is an important factor, but isolation is the other side of that coin. And both babies and nurses can feel isolated when they're working in a single family room area. Nurses work together as a team, more so in the newborn intensive care unit than in most other parts of the hospital. So we can deal with this if we have good design, if we have programs that bring families together and bring nurses together as they work, and if we are aware of this as a problem. In St. Paul, Minnesota, they had these touchdown stations, as they were alluded to earlier, between each 2 rooms. Beautiful rooms, very good outcomes in many respects. The staff perceived this private room environment to be better than the open bay in a number of different areas, as you will see. But because no central nursing area was provided for the staff, they felt that they didn't have a chance to collaborate with other members of their team. So these stations outside of the patient room are a good idea, but they should not replace a central area where nurses can gather to collaborate and socialize. This is a relatively old design in Oklahoma, but I think it has the features that we would like to see. To the left on this photo is the nurses' station, and there's an area there where nurses can collaborate in private. The patient rooms are arranged around the perimeter, so the family has their private area. But in the center is this beautiful area where both families and staff can gather together over lunch. You'll see couches towards the back of that central area where they can just relax. It's a beautiful area for this collaboration to occur and to relieve the sense of isolation. Just little alcoves at the end of a hallway can accomplish this too. Families are reluctant to leave their baby's room and go all the way to a family waiting room far outside of the patient care area. But they will go to these little areas in an alcove where there's a window and a coffee pot very near their baby's room and be able to come back and forth from the room easily. With respect to the staff, these 2 pictures show the same staff lounge with 2 different perspectives, the importance of windows. I think architects understand this inherently, and yet I see, at least in the United States, many hospitals still built without recognizing how important this access to nature is for our caregivers and for our patients. And so this outside garden concept is one that I've seen in many of your designs that you have looking forward, and is one that should be a part of every hospital. Again, this is something I know that architects understand, and yet in hospital after hospital, not only in the United States do I see it forgotten, that design is important for the spirit. that access to nature, scale, the grand scale of the hospitals and the hotels and airports that we see isn't always reflected in our healing environments. Color, form, whether it be just angles or curves. I see blueprint after blueprint of just square room after the next. And that isn't how our spirit is most nurtured. So a design that is functional but does not nourish the spirit treats all of us as something less than human. To the left is what many newborn intensive care units looked like in the recent past, and still many look this way. You would have to look very hard to find a baby or a family in this setting. And to the right is where we think things should be headed, where the baby and the mother are the center of our attention and everything else is around it as support. One strategy that I would propose to do this in the most economical way possible designs enough rooms to meet 90% of your high census needs when used as private rooms, but for each of them to be equipped as semi-privates. And this would take about 28 to 30 square meters with dual capacity head walls so that they could be used either for twins or in an overload situation. And then at least one larger room with at least 4 beds in it for higher order multiples, that's triplets or quadruplets, or for unrelated infants and families who prefer a community setting. In this way, families can have their choice of private or a more open environment, and the unit itself can flex up to 150% or more of the anticipated need. I think as we go forward within ICU design, we will see increased emphasis on sustainable design with greater use of daylight and natural materials, reduced use of electricity and water. Electronic communications are going to be our lifeline throughout the intensive care environment. Parents will become more partners in the medical care process rather than passive onlookers. Staff will be a resource that we need to take better and better care of if we're to retain them. And I think we will have increased utilization of specialized areas. Step-down units are very common already, but special units for tiny babies, surgery, or neurocritical care, I think are in the future. With these improvements, I think we can see reduced infection rates, a sensory environment that more closely approximates that the babies receive in utero, enhanced family participation and satisfaction, and increased staff health and satisfaction, as well as reduced environmental impact. These are a few resources. There are these recommended standards for newborn ICU design that are published online and will be part of a journal supplement in the next couple of months. There are a couple of books of clinics in perinatology on this topic and a conference in Florida that's held each year. Next year will be in February. So I want to leave you with this message again that nowhere in the hospital is the need greater to get it right. We're going through this crucial period of brain growth. No patient needs their family more, both emotionally and biologically. This is potentially life-changing for this family. Important things are happening throughout the hospital, that is clear, but nowhere so much as in the newborn intensive care unit where we are building brains and families for a lifetime. Thank you.
Thank you very much, Dr. White. اخواني الكرام، انا الصراحه يعني يتوجب علي حقيقه ان اشكر الجمعيه السعوديه للعلوم والعمران لدعوتي لاكون يعني رئيس جلسه واتعرف بهذه النخبه الطيبه من العلماء واتعرف على المعلومات الطيبه اضافه الى مقابله هذا الحضور والوجوه الطيبه. ثانيا شكري حقيقه العميق لزملائي المحاضرين لتقيدهم بالجلسات والاوقاتها. غالبا انا ارفض اراس جلسات لولا اصرار اخوان في الجمعيه، لاني اكره ان اقاطع علماء عن تقديم معلوماتهم واكره ان امنع الحضور عن سماعهم، وذلك اتقدم بشكر الجزيل كامل المحاضرين عندي لمساعدتي على انجاح هذه الفقره من الجلسه. ثانيا شكري العميق لكم مقدما لانكم من حسن استماعكم، وان شاء الله لمساعدتكم لانجاح الجزء المتبقي في جلستي وهي جزء الأسئلة والأجوبة. أكرمني المهندس حمد بحقيقة بتحدي أنه الوقت المتاح لنا 10 دقائق للأسئلة والأجوبة، فأرجو من الجميع صبر علي ويعني وتحديد 3 نقاط علشان بس ننجح في هذه السيشن. رقم 1 التعريف بالسائل، 2 تحديد السؤال المختصر، 3 توجيهه للمسؤول. فلو تكرمتوا لو تقيدنا ب3 عشان ننجح في إدارة الوقت، لأنه 10 دقائق يعني وقت قليل، وأنا أعتذر حقيقة بالنيابة عن الزملاء. تفضل.
My name is Abdurrahman Al-Obelan, Head Department of Study and Design in Ministry of Health, and also a member of this society. My question to Robert White, I think it's a good lecture when you show us for the NICU department. Is it, my friend, it's needed to have a step down for the NICU? So it seemed to me now, if he's well babies, if he's good, then he's gonna transfer to the just like not like an ICU. It seemed to me to be just an well babies. The other question is for the fathers and parents. Usually the doctor is not allowed for the people to, get inside the ICU because it's more clean and sterilized places. Is it may make a little bit difficulties with this problem? Thank you very much.
Thank you for these questions. So if I understand the first one, it is about step-down areas. There are two strategies for this. The European strategy is to have babies in an intensive care area and then to transfer them to a separate step-down area, often to a hospital closer to home. That's a very effective strategy. In the United States, it's different. We typically keep babies until they're ready to go home. That provides some continuity for the family, and that strategy works well too. I don't have a particular preference or reason to say that one of those is better than the other. With regard to infection, it is true that for many years we restricted access to babies on the theory that we were protecting them from infection. But what we have found is that virtually all of the infections that babies get is from us, from bacteria that we transmit back and forth and viruses. And that by allowing families extended contact with their baby, we actually reduce their risk of infection. So this question, this was one that I think had good intentions in the past, but we have now shown clearly is not necessary.
My name is Dr. Abdullah Sahimi. My question for the first presenter, you mentioned lean. I wonder how lean principles were used or were employed in design, and what kind of lean techniques, if there are any? Thank you.
Lean is a process of analyzing the waste within a operational process. And it's important when designing a new facility that all the key processes within the hospital go through an analysis of the efficiency of the process and eliminate the waste and the unnecessary steps in the process. Many times in doing that, it affects the space that you ultimately need. If you eliminate steps in the process, many times you find that in redesigning the space, you don't need as much space in your new facility because you're streamlining the process and eliminating points of the process or wasteful steps that were no longer needed.
نشكر الدكتور عبد الرحمن الطاسان على رئاسة هذه الجلسة، والآن نستأذن في تسليم شهادات شكر للمحاضرين. الشهادة الأولى للمهندس أحمد سويد من HDR ومهندس ستيف. مين الشهادة الثانية للمهندس كولين. الشهادة الثالثة للمهندس فيليب. الشهادة الرابعة للمهندس روبرت. ونستأذن الدكتور عبد العزيز الدوسري ليقدم الشكر للدكتور عبد الرحمن الطاسان على رئاسة هذه الجلسة. روبرت سوري، أنا ما شفتهم من هنا. الشكر والتقدير للدكتور عبد الرحمن الطاسان على رئاسة هذه الجلسة. شاكرين للجميع الحضور، والجلسة الثانية إن شاء الله ستكون الساعة 1:15 بإذن الله. الآن فترة صلاة، وحتى الساعة 1:15 إلى الساعة 1 تقريباً ستكون فرصة للصلاة والراحة.